Started here. Welcome to today's webinar. My name is Neeta Goyal. I'm a family physician and I'm president of Virginia Academy of Family Physicians, also chief medical officer for ambulatory services at Innova Health System in Northern Virginia. Thank you so much for your interest in COVID vaccination for pediatric patients. I want to go ahead and get started with just a few housekeeping items before we turn it over to our wonderful speakers for today, Dr. Leverson and Dr. Sprouse. So just a reminder that this webinar is being recorded and it will be shared with all of the Virginia Academy of Family Physician members. We will send you a link through the VAFP website. All of you attendees will be in listen-only mode to decrease the background noise. We want you to ask questions. So go ahead and use Q&A box at any time to send your questions. Our speakers will try to address the questions, respond to you as we go, and then we will address the rest of the questions towards the end to just make sure that we manage the time well. Today's webinar is worth 1 CME credit, and you will again receive the link for the CME survey in the chat function. And that's when, once you complete that, we will be able to assign you the credit. Besides that, I just want to go and get started. If you are really interested, just 1 second, should I share the slides myself? I want to ask the team, because I don't see the slides being shared.
Hi, Dr. Goyal. Yes, we are having a little bit of a glitch here with the slides. They should be up momentarily. I'm sorry about that.
That's all right. Well, I'm going to just go ahead and share a few things while we are working on some technical challenges here. So first of all, if you are interested in providing the vaccine for your pediatric patients, the process for ordering is the same as it has been for all the other vaccines, for the adult vaccines. We really encourage you to give vaccine to a lot of kids. So the point here is that even if you can vaccinate 1 child a day by opening a vial, it's worth it. We want to make sure that vaccination is encouraged over wasting of the vaccine. And that's directly from our team at Virginia Department of Health. They are not in any supply constraint. And we really just want to encourage everyone to give vaccine to the kids. So open a vial, even if you vaccinate 1 kid and you have to waste the rest of the vaccine, that's okay. So just the goal is to continue vaccinating. We want to go ahead and introduce our speakers for today. One is, my colleague and partner here at Innova, Dr. Rebecca Leverson. Welcome, Dr. Leverson. Dr. Leverson is a pediatric infectious disease physician and is division director for pediatric infectious disease at Innova Children's Hospital in Fairfax, Virginia, and the pediatric specialist of Virginia. In addition to working clinically, she has worked in the realm of hospital epidemiology and antimicrobial stewardship for the past many years, dozens of years at Innova Fairfax Medical Campus. She is an eager teacher and mentor of trainees, as she hopes to have excellent replacement for herself when she finally retires, which is long time away. Just want to make sure you're not leaving us, Dr. Leverson. She received her medical degree from Louisiana State University Health Sciences Center and completed her residency in pediatrics and fellowship in pediatric infectious disease at Children's National Medical Center, Washington, D.C., and the U.S. Food and Drug Administration, working in the Office of New Drugs. She has worked with the Virginia Department of Health on many infectious disease issues, including congenital Zika virus evaluation, cytomegalovirus infection, and a seroprevalence project of COVID-19 in children of Northern Virginia. She is interested in congenital infections, emerging infectious diseases, and antimicrobial stewardship. Rebecca is mother to her 14-year-old daughter, Madeline, who is honing her debate skills as she enjoys going point to point against her mother and father on nearly every facet of life. Yeah, very, very 14-year-old thing. And our second speaker is Dr. Chelsea Sprouse. She is COVID-19 vaccine pharmacy coordinator at the Virginia Department of Health. She received her bachelor's degree from Roanoke College and her doctor of pharmacy degree from Virginia Commonwealth University. At VDH, Chelsea works with pharmacy partners to ensure access to COVID-19 vaccine across Virginia. Chelsea continues to dedicate her time to advocate for the expansion of pharmacy practices and to help conquer the COVID-19 pandemic. In her free time, she spends time with her 3 cats and dogs and enjoys nature walks and hikes. So since we have the slides up now, let's go to the next slide. And just want to give you like very, brief overview how COVID-19 has impacted the children in Virginia, children, across the nation, of course, not only in Virginia. So this is just some little bit of data for you. The children under 18 years currently make up 18.8% of all COVID-19 cases reported nationally. This basically includes over 13.6 million COVID-19 child cases since the onset of the pandemic. The overall rate for child COVID cases, pediatric COVID cases, is 18,102 per 100,000 children. So that's very high. Child COVID-19 cases are, they are growing, like they're just, much higher rate now than compared to like a year ago, because they make up to 13.7% of the cases reported the week ending 6/16, which is just a week ago or so. Within the last 6 months, the data shows that younger kids, so ages 6 months to 4 years, they are experiencing much higher hospitalization rate compared to children who are age 5 to 11 years old. So this is why the emphasis on vaccination, and we are very thankful that you are joining here today to learn about the vaccination and are interested in providing this vaccine to your pediatric patients. So thank you so much. And without further delay, I am going to turn it over to Dr. Leverson.
Thank you very much, Dr. Boyle and the VDH team. I just wanted to talk a little bit about the pediatric vaccines 6 months to 5 years of age. So as you're likely familiar, there were 2 pediatric trials that were recently evaluated by FDA and by ACIP and have both garnered emergency use authorization for both the vaccines produced by Pfizer-BioNTech and also Moderna. So I wanted to walk through the clinical trials a little bit. One of the first things in pediatrics that we're very familiar with is that most of the vaccine trials that are performed in children are not powered for what we call specifically clinical efficacy, but instead they're based on immunogenicity data or immunobridging data. So what we do there is we look at the immune response that an adult made that showed that they had protection against SARS-CoV-2 infection. And we match that in children to see that children at the specific dose studied in the trials, that those children made the same or higher antibody responses. And so that was the design of these vaccine trials in all age groups of children. So that's, less than 18 years of age and then less than 16 years of age respective to the 2 different manufacturers. So really, we're looking at that immunobridging data to look at inferred vaccine efficacy. And then we also look at how many of those children made antibody responses. So we're looking at that serum response rate. And so we saw in both the Pfizer-BioNTech trial, which included children 6 months of age to 4 years of age, a 3-dose series of 3 micrograms of their vaccine over 3 subsequent doses, that after 3 doses of vaccine, that they met that immune response effectiveness or efficacy threshold. Additionally, Moderna, which has a 2-dose vaccine, 25 micrograms, 2 doses separated by 28 days, those pediatric patients enrolled in those trials also met the immunobridging efficacy endpoint also. So they also looked a little bit about, as we know that SARS-CoV-2 has changed over time, what the estimated efficacy was for those children based on newer variants. Next slide, please. So additionally, all of the clinical trials looking at vaccine also look at safety and reactogenicity. And so for any vaccine, and as we've seen with the SARS-CoV-2 vaccines, there's a very rare incidence of anaphylaxis. So anaphylaxis was evaluated in both of the trials, but no cases of anaphylaxis were identified in either of the trials. And we're talking about 8,000 or so children in this age group who were evaluated. Additionally, there were no reports of myocarditis or pericarditis in this age group, and there were no children who died during either of the clinical trials. We did see, similar to older children and adults, that the typical side effects were injection site pain, a little bit of tiredness, a bit of fever. We'll go through that in a little more detail in later slides, and then a little bit decrease in appetite in some of the children. So next slide, please. So just to go through a little bit more of the nuts and bolts of the vaccines, and Dr. Strauss is going to go into this a good bit more. We know from these clinical trials that both the Pfizer-BioNTech and Moderna vaccines are highly effective in preventing symptomatic COVID in these pediatric populations. However, the doses are different. And so you can't just use the dose from an older child or from an adult to use that same dose of vaccine or the same vial of vaccine for these children. So the Pfizer-BioNTech vaccine, again, is 3 doses. The interval between dose 1 and dose 2 is 3 weeks, and the interval between dose 2 and dose 3 is at least 8 weeks. And most of the clinical trial participants, it was between 11 and 12 weeks. The dose that children are given in this age group is 0.2 milliliters. And then for Moderna, it's a 2-dose vaccine, 6 months through 5 years of age. And those vaccines are given 4 weeks apart. And again, that's a 0.25 milliliter. Next slide, please. Some additional information. So the Pfizer-BioNTech vaccine comes with all of the additional supplies that you'll need. There's a diluent that's needed and the pediatric needles, the 1-inch needles. And the Moderna vaccine doesn't need any diluent, so it comes with those 1-inch needles. The minimum quantity that you can order these vaccines is 100 doses, but as Dr. Goyle mentioned, and our VDH partners very much advocate, it is much more important to get a dose of vaccine into a child than to miss that opportunity. So if you have to throw away 9 doses out of a vial, then that is preferred over missing that one child who could have gotten vaccinated. There are training sessions available. And next slide. So for a little bit more detail, I'm going to have Dr. Strauss go through some of the more information here, and then we'll come back to talk more about the clinical aspects and frequently asked questions.
Alrighty, thank you so much for that great introduction. So I'll kick us off here with some specifics about the 2 vaccines. So I want to point out there was a little bit of mislabeling on the early labels of the Pfizer vaccine. So what happened was that they had created these vial labels prior to what they actually knew about that vaccine. So they didn't know what the stability was going to look like exactly. They didn't know how low the age group was going to go and that sort of thing. So just to be safe, they labeled it as such. So if you look at the picture here on the left-hand side, you'll see a little caption there that talks about the discard after time. So you'll see on some of the vials, especially some of the earlier shipments, it might say to discard after 6 hours, but the vaccine is actually good for 12 hours after dilution. If you look on the right-hand side, you'll see another box that indicates the use for the age ranges. So some of the vials you might get, they may say ages 2 to 5 years old, but it's actually 6 months to 5 years old. So if you receive any of these mislabeled vials, just know that it's good for 12 hours, and it is in fact good for the 6 months to the 5-year-old population. Next slide, please. And to go into a little bit of the storage and handling for the Pfizer vaccine, as you can see, compared to the other vaccines, so the gray cap and the orange cap, the storage conditions are essentially the same. So just going through as a refresher, in the ultra cold freezer, these vaccines are good for 12 months from the manufacture date. And then once they are moved into the refrigerator, they are good for 10 weeks. So upon arrival, if you get them and they're frozen, do not put them in the regular freezer. They should go immediately into the refrigerator. And then at that point, they're good for 10 weeks. Then at room temperature or after the first puncture, they need to be discarded after 12 hours. And Pfizer does have a cool little QR code that you'll see on the bottom, and that will take you to the website where you can actually put in the lot number and everything, and that will tell you when the expiration date is for that particular lot number. Next slide, please. And then going into a little bit more of the details. So for this vaccine, it does need to be diluted. The amount of diluent is different from that of the 5 to 11-year-old population. So you do need more diluent. So it's 2.2 mLs of diluent that you'll add to the vial of vaccine, which brings it to a concentration of 3 micrograms per 0.2 mLs. So with each vial, you'll get 10 doses per vial after it's diluted. One thing I always like to tell, and they suggest this, not to mix residual amounts from each vaccine. So if you have a little bit in one vial and then a little bit in another vial, do not combine those. If you don't have enough to pull up a full dose, just go ahead and get rid of that vaccine. And just to reiterate the dosing schedule, you'll see at the bottom. So between dose 1 and 2, you'll wait between 3 to 8 weeks. And then between doses 2 and 3, it's going to be at least 8 weeks. Next slide, please. Alrighty, so this has been a common question that we've gotten over the past week or so. So what if you have a child who will turn from age 4 to age 5 between any of the primary series doses for this Pfizer vaccine? So you really have 2 options, and I like these pictures. They lay it out pretty clearly here. So with scenario 1, you can either do a 2-dose primary series with the older age group population, so the 5 to 11 orange cap vaccine. Or you can look at scenario 2, where you can use sort of a combination of the orange cap and then this new maroon cap. So for example, you say you have a 4-year-old, you go ahead and give them 1 dose of the maroon cap vaccine. Then 3 to 8 weeks later, say they turn 5 years old, go ahead and give them either the maroon cap or the orange cap. Then for the 3rd dose, it's the same. You can choose either the orange cap or the maroon cap. Just as a rule of thumb here, I do like to just say, just to give the appropriate age vaccine for your patient. So if you go with scenario 3 and you start with the maroon cap, for example, the maroon cap historically is a 3-dose series based on that age group. So you stick with the 3-dose series. Even if you switch it up to orange cap in scenario 2, you still need to make sure that they get all 3 of those doses. Next slide, please. Alrighty, diving right into Moderna. Just going over the storage conditions. Again, this is very similar to the Moderna vaccines that we see that are available now. So in the refrigerator, they are basically good up until the expiration date. So on the carton, they have a QR code. You can also use the QR code at the bottom of this screen to pull up the storage and expiration information specific to that carton and lot number. Then when we look at the refrigerator, it is good for 30 days prior to the first use, once it's moved into the refrigerator. Once the vaccine vial is punctured, so regardless of if it's in the refrigerator, if it's at room temperature, if it has been punctured, it must be discarded after 12 hours. And also with the refrigerator, if you get a vaccine that's been that arrives frozen and you put it into the refrigerator and it thaws over a period of time, it does not go back into the freezer. And again, if you get a vaccine that is already thawed out, do not put it in the freezer. It goes directly into the refrigerator. At room temperature, if you have a vial that has not been punctured, it's good for 24 hours. And then again, if it has been punctured, it is good for 12 hours. Next slide, please. And a little bit more about these specifics. So again, this vaccine is for 6 months through 5 years old. It is for a primary series of 2 doses, which is a 4 to 8 week period in between doses. Moderna has come out with a additional dose for the immunocompromised patients. The Pfizer vaccine at this time does not have that, but Moderna does allow a third dose, a third primary dose for your immunocompromised patients, and that's going to be 4 weeks after the second dose. All of the doses in these primary series are 0.25 mLs, and it does not require dilution. You can see on this picture, I do like this picture, however, it is kind of confusing. So of course, this first box is what we're talking about right now. This second box that shows the teal kind of color, that vaccine right now is not currently available. So don't really want to confuse you here, but this is just to kind of compare all the different options that are out there. This is not the purpose of this vaccine, but just to draw, or this webinar, but just to draw attention to the purple vaccine that's in the third column. That one was recently authorized just last week as well. So you'll see that vaccine circulating as well. And then lastly, the last vial is the one that, we've all seen that one. That's the one that's been out since Moderna became available. Next slide, please. Alrighty, and then again, with Moderna, there are some stipulations as far as, if your patient's in between ages or if they turn 6 years old after starting the series. So Moderna has come out and said that pretty much either dose, you can choose whether you want to do the new younger child vaccine, which is the magenta label border, or if you want to do that higher dose for the 6 to 11-year-old population. So for dose 1 or 2, you can choose between either of those vaccines, as long as it's been 4 to 8 weeks between the 2 doses. Next slide, please. Alrighty, so what about mixing and matching? So for children who are in this age group who receive different mRNA products for their first 2 doses, so this example here shows a dose 1 of Pfizer and then a dose 2 of Moderna, they could receive a third dose of either of those mRNA vaccines as long as it's been 8 weeks since their second dose. So these kind of stipulations can get very confusing, which is why I like these pictures that Moderna and Pfizer have provided. There are links to the documents where I got these pictures from as well, if you'd like to reference them. Next slide, please. Alrighty, and now we're just going to go into a little bit of eligibility when it comes to pharmacy. A lot of times doctors don't provide all vaccines that would ever be available for any patient. We hope that a lot of you are going to be carrying this COVID vaccine. However, we want to make sure that you all are aware of what pharmacists can do in the pharmacy, because it's not the same as all other healthcare providers. So with the PrEP Act, pharmacists can only vaccinate down to age 3. I'm sure this is not new, but I do want to just bring this to your attention. Even if a doctor writes a prescription for a patient under the age of 3 to get a COVID vaccine to take to the pharmacy, that pharmacist still cannot vaccinate that under 3 years of age patient. Because these vaccines are under EUA, they don't follow the same laws and regulations that are in place for other vaccines. So this slide is very important for that matter. If you do have patients younger than 3, please do not refer them to a pharmacy to get the vaccine. Also, to bring your attention to the little box at the top, that's vaccines.gov. If you're having a hard time finding somewhere who is going to vaccinate this age population, either you or you can refer parents and guardians to go to vaccines.gov. If they have not already changed it, I know they were in the process of changing it to indicate which vaccines each pharmacy will carry, as well as what ages they'll vaccinate down to. So even though pharmacists can vaccinate 3 and older, a lot of pharmacies are only vaccinating, for example, 5 years and older, or even 18 years and older for that matter. So I have listed there at the bottom some of the big chains that have said that they're going to carry this younger population vaccine. However, they are not, most of them are not carrying them at all locations, just select locations. So I would definitely recommend your patient to call the pharmacy before you send them, just to make sure that the pharmacist there is going to be able to vaccinate that child. Next slide, please. All righty, and I will hand it back over. Thank you so much.
All right, so wanted to go over some more things in regards to questions that families are likely going to ask you in regards to COVID-19 and why vaccine is an important thing for children regardless of age. And so all of us know that the pandemic has affected everyone's lives, including children's lives, and not only from just the infectious disease perspective, but in regards to all other realms of life. We certainly continue to see children who are having severe illness, being hospitalized, having long-term complications, including multi-system inflammatory syndrome or long COVID. And the best message that we can send is that vaccination is the very best way to protect every single individual against this infection. Next slide. Some other things that it is important to be able to be aware of so that you can share with families is that these vaccines are proven to be safe and effective. They do help protect. They may not protect you against acquiring infection 100%, but they do provide that protection and against more severe illness and hospitalization and death. All of the vaccines remain free and readily available, and they can be co-administered with other vaccines. Next slide. So I wanted to go into about 7 frequently asked questions that families are likely going to ask you so that you will be armed with good answers. Next slide. So one of the first questions that comes about, and I think that, this goes all the way back to 30 months ago when there was this myth that children didn't seem to get ill or even get COVID infection. And I think that we clearly know that SARS-CoV-2 infects all age groups and can infect children to a severe degree. And so one of the questions is, does my child really need to get the vaccine if my child's not going to get very ill? For example, I don't think my child has any high risk conditions. So it's unlikely that they're going to get ill. And that's what a lot of families, have thought about. And we've talked a lot about adults and comorbid conditions, and we've been able to really look at comorbid conditions in adults and predict a little bit more, obesity and other comorbid conditions put you at higher risk for more severe disease. That really hasn't been worked out in children well at all. So my answer is, yes, every child should be vaccinated. We should take every opportunity to vaccinate every one of these children because number one, we can't predict well who's going to get very sick or who's going to die from COVID-19, and that certainly includes children. And the other thing is that children's health status changes over time. You in the office are diagnosing children with diabetes or with obesity or with asthma or with acute leukemia, you're making these diagnoses every day, or you have suspicions of them and you're confirming these diagnoses. And so to be able to vaccinate when the child is healthy is going to provide a better response, especially if they're going to have to become immune suppressed at some point in time. The other thing that has been borne out with data clearly is that prior infection is not sufficient to provide you protection against the other variants. And when we compare that to vaccination. So next slide, please. So we can see this comes from the cumulative hospitalization data in children over the start of the pandemic to early May of this year. And you can see in the older age groups, those were the ages where we saw higher rates of hospitalization in that sort of 12 to 17-year-old age group. But now over the last couple of months, the youngest population, this age group that is now available finally for vaccine, they have outstripped the total hospitalization of all other age groups. Next slide. Additionally, COVID-19 over the last 2 years has been one of the top 5 causes of death in children of all ages. And so we can see that COVID-19 ranks number 4 or number 5 in the cause of death throughout the pandemic to date. Next slide. One of the other questions that families will likely ask is about reactogenicity. Will my child get sick after the vaccine? So this is an intramuscular vaccine. And so with that, we see that somewhere between 1/3 and 2/3 of children will have some pain at the injection site that typically goes away within 1 to 2 days. A couple of percent of kids will have a little bit of redness. Some will have a little bit of swelling. And Moderna looked at how many children had any axillary swelling or tenderness, and it really was with the first dose comparable to placebo, and with the second dose almost double. Next question, next slide. When we look at systemic reactions, we did see with the Moderna vaccine that about a fifth or so, up to about a fifth or so of kids would have a fever with the vaccine, more so with the second dose than with the first dose. With the Pfizer vaccines, those 3 doses, really the degree of fever was pretty comparable to just the placebo rate. One of the other things to remember is that the Moderna trials and the Pfizer trials were both done during the time of lots of winter respiratory viruses. So many of these 6-month to 4-year-old children had concomitant viral illnesses. The other thing that we saw with second dose of Moderna is a little higher rate of muscle ache in the next day or so after, a little bit higher headache, about double, 16 to 8% in the placebo rate, and then a little bit of nausea, vomiting, and chills. About a fifth of children did get some antipyretic or anti-pain relieving medicine after vaccination. And we've had a number of pediatric studies that have looked at avoiding giving paracetamol or acetaminophen's near equivalent prior to vaccination, because what we see is if you give paracetamol prior to vaccination, you actually blunt the immune response. So it is preferred to let the child, get the vaccine. If they develop symptoms of fever, muscle ache, etc., then it's fine to give them Tylenol, ibuprofen, something like that. Next slide. So what about if my kids already had COVID-19? Do they still need to get vaccinated? And so we know that, and even included in these trials, children who had prior COVID infection made much better, much more robust antibody responses after having disease and vaccination. So this slide looks at reinfection rates in people who only had history of disease, and then those who had prior infection and vaccination. And we can see that there is a much higher rate of protection against disease again if you get vaccine and you've had disease. So for everyone who's had disease, this is extra icing on the cake. This gives you that hybrid immunity that we're looking for. And we see that people who have not been vaccinated but had prior disease drop down in their effectiveness of just having natural disease to about maybe 20% or so. And so you're just going to get it over and over and over again. Next slide, please. So in those children who've had COVID infection, which approximately 75% of children to date, based on blood sampling studies, so seroepidemiologic studies, have shown that children have had infection, how soon after that infection can the child be vaccinated against SARS-CoV-2? CDC says that you can wait up to 90 days from having illness to get vaccinated, but I would argue that that's actually some pretty old data. One of the things that we know is that children, as soon as they're out of isolation, can get vaccinated. If you have disease recently and you get vaccinated, that reactogenicity, so the fever and the muscle ache, may happen more commonly with the first dose compared to that second dose of vaccine. The other thing that's really important to know is that circulating right now, the majority of the SARS-CoV-2 that has been genotyped in the United States of America are actually now BA4 and BA5. And prior infection with Omicron over last winter does not provide you adequate protection against getting BA4 and BA5. So it's the opportune time right now to get those vaccines in, as we're seeing BA4 and BA5 starting to outpace all of the other Omicron variants. Next slide. One of the questions that you are very likely to receive is, what is the risk of myopericarditis with these vaccines? So in this trial, in these two trials of almost 8,000 children, 6 months to 5 years of age, there was not a single case of myopericarditis seen. Additionally, this age population has a very low rate of myopericarditis. So with that, we expect that the rates of any vaccine-related myopericarditis are going to be very rare. When we look at older age groups, you can see to the 5 to 11-year-old boys with the second dose of vaccine, you can see that they had a slightly higher increased rate compared to what is estimated just from viral infections alone. And that increases to a higher proportion in 12 to 15-year-olds and 16 to 17-year-old boys. So that's about 3 per million doses of vaccine in that 5 to 11-year-old boy population, whereas in girls, we really did not see that at all. When you look at 12 to 15-year-old boys, you can see about 46 per million is the rate. And I would just also tell you, having seen probably a dozen or so of these kids who had vaccine-related myopericarditis, it is a much milder illness compared to viral myocarditis, which certainly can happen with COVID infection. Most all of the children who and young adults who have been followed to date with vaccine-related myopericarditis have had at 90-day follow-up full or near full recovery, meaning that their cardiologists have signed off on them saying they look fine. The other thing that we see is we don't see a significant increase in myopericarditis with subsequent episodes and with subsequent doses of vaccine to date. The other thing that's very important to know is the CDC did authorize widening the interval between doses, and that appears to decrease that risk of myopericarditis. So for example, you have a 4-year-old male in your office and the family is hesitant on giving dosing at, time 0 and then 28 days. So you could lengthen that out all the way to 8 weeks, especially if they had a recent case of COVID infection. They've got some immunity from disease itself. You'll give them 1 dose. You can give that next dose sort of further out. So this is a slide that will be available to you too, that comes from CDC ACIP. Next slide. What about giving other childhood vaccines at the same time as a COVID vaccine? So the CDC, ACIP, and American Academy of Pediatrics all support co-administration of COVID-19 vaccines with other vaccines on the immunization schedule. There have not been any direct studies of immune responses with COVID vaccines plus other childhood vaccines. However, there have been many studies of multiple combination vaccines given in children, and we didn't see any decrease in the immune response in those people who got multiple vaccines at the same time. So with that, I think it's quite reasonable. And one of my partners, her son turns 1 tomorrow, and so he will get all of the fabulous 1-year-old vaccines, MMR, varicella, and his first dose of vaccine. of COVID vaccine. Next slide. Just like Dr. Sprouse went over, in children who have moderate to severe immune compromising conditions, they do warrant an additional dose of Moderna vaccine. FDA and CDC don't have enough data on the Pfizer vaccine to know if a 4th dose is warranted as part of this primary series. So my clinical opinion would be, if you have a child who has moderate to severe immune compromising state, I would preferentially get Moderna because I know that they're going to get 3 doses as part of that primary series. Next slide. So what about children in booster shots? Are they going to need, is this age group and the 5 to 11-year-old age group, are these children all going to need boosters, and how many? So we really don't know at this time. FDA VRBPAC meeting met today and discussed and voted 19-2, saying that they support an Omicron combination vaccine. And so with that, an ancestral strain plus an Omicron variant strain. And so with that, they should have vaccine available for older age populations. And there was a significant plea from peds infectious disease physicians who are part of VRBPAC to make sure that the booster shots that are included with an Omicron variant are studied in children too, so that we have all of this immunobridging data just like we would have in adults. And both Pfizer and Moderna are studying different formulations of vaccine, both ancestral and Omicron variant in this young population. Next slide. So which of the 2 vaccines should my child get? I've not been asked this question ever before, about every day, multiple times a day. So what I want to tell you is both of the vaccines met the emergency use authorization criteria. They met the endpoints. They are both authorized. There is a little bit of uncertainty regarding the data with some unblinding that occurred with the Pfizer trial. So it was part of the protocol that at 6 months, the children were unblinded and they looked at their immunobridging data, and they found that after 2 doses of vaccine, they did not make high enough antibody responses. And so all of the children who were in the placebo group got rolled over into active vaccination. And so with that, there's a little bit of concern about, did you report all the side effects? You knew you got the vaccine. How did that modify your activity, et cetera, et cetera. And then there was also some very wide confidence intervals in the efficacy. So Pfizer said, based on their descriptive efficacy analysis, they said, well, our 3-dose vaccine provided 75 to 80% protection against symptomatic COVID. Well, their population was a total of 10 kids in both arms of the trial who got COVID infection. So I think that we need more time to know really what the true efficacy is of the vaccines. And that will be continued to be studied by CDC and others through multiple different avenues. The other thing is that Moderna has a potential increased signal for fever. And so we might see that with that 2nd dose, you might have a little bit more fever, maybe up to about 16 to 20% of children might have a fever. Most all of the children had, really low grade fever, less than 101, and maybe, 101 to up to 102. Very few had 104 fever. And this age child is really the age children who have lots of fever when they get vaccines, and they mount higher fevers than certainly older children and adults. There was one child in the Moderna trial who did have a febrile seizure with the 1st dose of vaccine. That child was, I think, 19 months old, went on to get the 2nd dose and didn't have a fever and didn't have a febrile seizure. And so that is something that is not uncommon in this age population. So just something to watch for. And certainly you can give antipyretic with fever in any of these children after vaccine. The other thing that's really important is that you've got to finish the entire series to be protected. So that's 2 doses of Moderna a month apart, or 3 doses of Pfizer. Again, 3 weeks apart, at least 8 weeks after. And so that really brings you to about 4 months before you're, truly protected. So 2 months versus, 4 months. Next slide, please. So I just want to, leave you with a little bit more information, sort of summarizing this. You are the trusted source. You are the trusted messenger for these vaccines. for these children and for all ages. And so it is imperative that you feel comfortable discussing with parents who are wanting to discuss with you the pros and cons of vaccine for their children. Be familiar with the reactogenicity profile. Be familiar with the fact that a history of disease plus vaccination provides better protection for all age individuals compared to a history of disease alone. Also, be able to, discuss with families candidly that the vaccine goal is really to prevent severe disease, hospitalization, and death, and it has continued to do that. We can't predict who's going to have that risk factor. Over the last month or so, we've had a significant increase in children admitted to the hospital with acute COVID infection and respiratory failure. Most all of those children are unvaccinated. Most all of those children are under 5 years of age and haven't had opportunity to vaccine. And many of those children did not have any known risk factors. And so again, between 6 months and a couple of years of age, that's when you're figuring out, do you have asthma? Do you have other, conditions that put you at, potential higher risk? And so the other thing is, to be fully protected, you've got to finish the series. To be able to just get one dose of vaccine is probably not going to provide you enough of a protection as we desire and as you desire. Next slide, please. And so with that, I'll turn it back over to the moderators.
Thank you so much, Dr. Leverson and Dr. Sprouse. That was very, very informative, and I'm sure the participants, they have now greater insight into COVID vaccine for their pediatric population. Some of the points you made around, making sure allowing the co-administration of the vaccines with other vaccines, or not waiting for 90 days after having COVID infection, are so important, not just for this pediatric population, but for everybody who is eligible to get COVID vaccine. So really keeping that in mind, because we still continue to get lots of new variants, and it's really, really important for everybody to get vaccinated. So we are happy to take your questions. I see that there was a question that was already answered in the chat, but if you have more questions, please go ahead and send it to the chat. But in the meantime, I also want to remind you just on the next slide here that there are additional resources that you can review, and we will be sharing this slide deck as well as the recorded webinar with you on our website, the VAFP website. So there are lots of resources from CDC, VDH, and VAFP that you can also go to and get more information. On the next slide, there's some CME information to get the credit for today's session. You will just need to do the survey, which we will be sending you through the chat. Okay, that's right there. Mary Lindsay sent that. So make sure to copy that. And as you finish the survey, then we will be able to assign you the credit that you need for this session. With that, I also want to thank Virginia Department of Health team here for arranging this webinar for our membership. Thank you so much on behalf of the entire Academy. And we are very happy that you are supporting our efforts in this vaccination. So I'm going to give another minute or so to see if there are any questions. Otherwise, we will close. All right, I think I am going to give less than a minute and give you actually 10 minutes back of your time. So thank you again, Dr. Leverson, Dr. Sprouse, VDH team, and the VAFP team who's on and helped arrange this webinar. Have a good night.